Welcome to episode 107 of Concussion Talk Podcast. I'm Nick Mercer. And today my guest is Lenore Herget, who is a DPT, PT, DPT, and just knows a lot about concussions. And to say his expertise there is an understatement. But we'll get more into what she's saying. First, I want to just remind everybody that they can follow me on Twitter, Facebook, and Instagram at Concussion Talk, to please support me on patreon.com. So patreon.com/concussion talk, and subscribe, rate, and view this podcast wherever you get your podcasts. And before I talk to Lenore, I'll introduce my sponsor, HeadCheck Health. Concussion Talk Podcast is presented by HeadCheck Health. HeadCheck Health bridges the gaps in concussion care through simple, powerful technology. Join organizations like the Canadian Football League, Track Factory Racing, the Canadian Junior Hockey League, Eastern Washington University, and Volleyball Canada, who rely on HeadCheck Health to improve communication and optimize care. Visit headcheckhealth.com for more. Okay, Lenore, thank you so much for agreeing to be part of this podcast. And so as I kind of stumbled through your expertise here, but I'm trying to read off your Mass General is where you work. Is that where you're now? You're in Mass General Hospital?
Exactly. Mass General Sports Medicine Department.
Right. Okay. And there's a long bringing your bio here on the page, and it's extensive. So I guess your choice is what you'd like to know about you is that you're a senior physical therapist, and you obviously do almost specifically concussions or also orthopedic side. So yeah. So what's your?
Yeah, I do a little bit of both. So probably 60% of my caseload is sport-related concussions, and then the rest is other sport-related musculoskeletal orthopedic injuries.
Wow. So you're a busy person. You will be, I'm not sure when in spring, I guess it is, it'll be early spring or late winter, when you teach a course for Jess Schwartz, who's on episode 103 of this podcast. She's doing Concussion Corner Academy, and one of her courses is physical therapy examination, which Lenore will be instructing. So could you just, I guess first start off talking about that. What are you going to teach in that in general?
Sure. So the Concussion Corner Academy, I believe we'll be getting off the ground in January. And I think I'm the third lecture. So sometime late January, mine will be going live. So my role with Concussion Corner Academy is to teach the functional exam for concussion. I'll be focusing on the ocular motor, so the functional vision exam, the vestibular exam, the cervical spine exam, and then exercise testing considerations. So kind of all of the exam and clinical assessment with concussion will be my role.
Oh, well, so you still have you teach for 2 weeks? You instruct for 2 weeks?
Yes.
Okay. And so what is the role of, what would you first say your evaluates just in general, and not to get the course away here, but cervicogenic testing, how would you proceed with that? With your examination, how would you proceed with that with your in general, just for layman's audience?
Yeah, sure. It's a good question, because a lot of times we kind of forget how much the neck is involved with the head, and how you can sustain a concussion without even hitting your head, just by the sheer force of your neck and head in a whiplash type mechanism. So because of that, a lot of the symptoms and what these people feel are very similar to the symptoms of a concussion, where they might have headache and dizziness and fogginess, but that could actually be coming from the neck.
So part of like whiplash, pull you off the neck.
Exactly. Right, exactly. Just like a whiplash induced injury. And so it's often concomitant with the concussion. So you're getting a neck injury with your head injury. So the cervicogenic part of the exam is to try to tease out, is the neck contributing to what they're feeling, or is it just the head?
And
So there are a few
sorry.
different, oh, sorry.
I was going to say, you were going to say, I was going to say, hey, do that, but you were going to say that. So
Yeah, sure. So obviously you would do your regular musculoskeletal workup, looking at ligament stability, range of motion, joint mobility, muscle palpations, strength testing. But what separates this from a regular orthopedic or musculoskeletal exam for the neck is getting into the sensory integration and proprioception testing. So there are a few good tests out there that have good sensitivity and specificity. So the ones that I use mainly and that I'll be teaching, one of them is the Smooth Pursuit neck torsion test. So it looks just like your regular Smooth Pursuit test, like an H test or an I test that you would be doing to look at eye movements.
Yeah, I was going to say something.
Yeah, it's exactly like that, except you have the patient rotate their head 45 degrees to one direction, and you repeat the test, and 45 degrees the other direction.
Like instead of your eyes following a pen or whatever, your whole head does. Is that the?
It's still just your eyes.
Okay.
So it's straight across from your patient and having their head and neck in primary position, just looking straight ahead. Now they're rotating. So you're going to be at an angle. You're still going to just watch their eyes move, but there's some torsion now through the neck. The neck is rotated. Otherwise, you do the exact same H test for Smooth Pursuit. And so what you look, does it feel different for the patient? Sometimes it causes more eye strain. And do you notice any breakdown of eye movements? So if it was smooth when you were sitting straight across from them, but now it's all saccadic and kind of choppy, that indicates that there may be some more contribution coming from the neck. Or if it hurts them more or causes more of a headache when they do the H test or the Smooth Pursuit test, if it hurts more or causes more symptoms when their neck is rotated, that's an indication that the neck is likely involved.
Well, I've actually done a few podcasts on the visuo-vestibular system with Thrive Neurosport. She's Katie Mitchell is a physiotherapist and PhD researcher, PhD candidate again now in Waterloo, Ontario. And she did a few episodes of the podcast, and so did Lauren Zacks, who's the DPT in Utah. Do you know her?
I do know, Lauren.
Yes. And so we did a face concussion podcast together. We still do it when I haven't talked in a while, but we will. And so I'm very familiar with the visuo-vestibular system treatment for concussion. But could you just please explain what you see in it? What's your take on the whole vestibular system and how you would examine that?
Right. So first, when I look at visual or vestibular?
The visuo-vestibular system. So not the system, but the treatment.
The whole thing. Yeah. So when I'm looking at the visual vestibular, the first thing I want to do is make sure the visual piece is working before I even examine the vestibular. If the ocular motor, the visual system's not working as well as it should, then that's going to affect the vestibular system too, because of the vestibular ocular reflex. So I do my thorough vision exam first, then I go into more of our vestibular visual acuity, dynamic visual acuity, things like that. And so any part of the system that's not working, from eye alignment to eye tracking at different speeds or depths, we want to make sure we're addressing that, and then bringing in the head movement piece to bring in the vestibular system to look at gaze stability as well.
I can definitely see that, because actually my brain injury was a severe brain injury, not concussion, severe brain injury. 3, and I've had double vision since my brain injury, and 3 eye surgeries. But now I'm doing vision therapy locally here at the Vision Development Center there on August. Katie, actually, Kara and Sarah were on my podcast. And so I've done a lot of this vision stuff with eye tracking and trying to get my eyes aligned. Well, not really aligned, because one is just a distortion, like it's the eyes twisted in the socket, I guess. And Yeah, so I definitely feel the importance of this of getting your eyes aligned and helping that helps a lot with the vestibular system with this. So once you have I mean mine are probably never going to align because of physical limitations with due to surgeries and my injury stuff. So but who knows? And maybe they'll, I shouldn't say they never will, but I mean, I don't know. Anyway, and I'm not a doctor, but so what if once you decide that this person's that the client's eyes are, I'm not saying not going to say not the problem, but not going to affect your fist or have been treated enough that the vestibular system. How would you treat the vestibular system?
So sure. So then I want to get into tolerated head movements while making sure the vision is stable or the vision is clear. So it may mean that we have to slow down the pace of the head moving while looking at an object in a pretty simple room or simple background. So normally we should be able to keep a target still or in focus while moving our head at 2 hertz or 180 beats per minute with a pretty busy background. That's what we should be able to do, but that's often impaired, right?
Yeah.
So I try to find whatever a patient can tolerate and do objectively well. So how fast can they move their head and keep an image in focus without provoking symptoms to a great degree. If it provokes symptoms in up 1 or 2 points on the scale and comes right back down, that's fine. But if it's really skyrocketing their symptoms and they can't see the target clearly, then I want to make sure I'm slowing down the head movement and maybe using a pretty simple background. And then as we progress, we'll speed up the head movement, add a more complex background, maybe change the base of support. So starting off sitting and then moving to standing and maybe incorporating balance or movement of the whole body within the room until we get to the point where they're doing what they need to do for their occupation or their sport.
I see in your pilot that you do a lot of this, Brad, in your pilot that you do a lot of work with exertion and exercise. So, and you're saying like sit and stand, and their eyes are coping with that, but and their heart is coping with that. But so how would you introduce, say, your any exertion or exercise right after when you in the mid during the treatment, or do you wait till after that's you have a better handle on that? So either visual motor system or the visuo-vestibular system, or would you introduce the heart rate and the exertion at the same time as you're studying you're examining their visual system?
That's a really good question. And as you know, everybody's so different. So what I might do with one patient can be very different from someone else.
That's true.
Typically, I examine each system in isolation. So examine the ocular motor, examine the vestibular, examine exercise or cardiovascular endurance. And then based on results from each system, develop my plan of care. And then within a treatment session, I might start in a similar fashion where we do a few eye exercises and then a few vestibular exercises and then some exertion or cardiovascular exercises. And then, over a couple sessions, start to combine and mix these challenges. So do an eye exercise while balancing, do a vestibular exercise while riding a bicycle. So we start to incorporate multi-system challenges as they are getting better.
And these exercises would not be hard. Would they be exertion? Would they be at the upper threshold of this person's ability, or are they just ready, like just going to the market, getting a bag of potatoes or something like that? Are they like very slow, usually a bike ride, or would they be a harder, more training type of bike ride?
Yeah, so another great question, and it can vary so much. So I ideally want to establish a threshold when I initially examine them. So is there some sort of exertion threshold based on heart rate or position? that they can tolerate. And so that's where I'm going to start. So for some people that might be running on a treadmill, but for most people, it's going to be a lot less than that. It might just be walking down a hall, or like you said, going to the market and picking something up. So it really is dependent. But the key is trying to stay below a threshold where it really exacerbates symptoms.
I want to ask you about your protein affiliations, but also first, you also do a lot of high school patients, clients, however you help them patients or clients?
I usually call them patients.
Patients? Yes.
Yep.
Well, your high school patients but are they usually from sports, or are they just generally, are they specifically from, like, say, level high school football teams or hockey teams?
Yeah, so my patient caseload is probably 95% sport-related injuries. So I'm typically seeing soccer players, basketball, lacrosse, hockey, football. Once in a while, I'll see non-sport related injuries, maybe car accident, a fight at school, something else like that. But most of what I'm seeing is sport related. And
I was going to ask you the treatment you give to high school athletes. I assume also, younger, obviously just kids, whereas pro athletes are adults. So does the way you treat the concussion differ significantly from, like, say, your focus on visuo-vestibular or cervicogenic? Does that feed into it as much?
Yeah, I mean, for both groups, for the pediatric or the younger population or the adult professional population, I mean, it's still the same brain. It's still the same systems that we need to examine. The biggest difference is that with the kids, they're still undergoing a lot of neurometabolic changes. They still have a developing brain. So a lot of things that just are impacting their recovery outside of their head injury. They're developing, they're still changing on a day-to-day basis. Their necks are generally weaker than a professional athlete's neck. Yeah. And so, but otherwise I'm still examining oculomotor, vestibular, cervicogenic, exercise tolerance. So it's still all the same exams. It's just taking some of those factors into consideration.
And this practice that we were both mentioning, or the New England Patriots, you're on the medical staff of them. You see Boston Bruins, Boston Red Sox, New England Revolution. What is the home base program? I read that, but I don't know what that is.
Sure. The home base program is initially it was started to treat veterans of post 9/11 wars. So to give them some supplemental assessment and clinical treatment across the spectrum of physical and emotional and mental impairments sustained in post 9/11 wars. So it's a 3 to 4 day evaluation with multiple disciplines. And then if they qualify for either the TBI or the post-traumatic stress group, they come back for 2 weeks of intensive training. And that's physical therapy, occupational therapy, speech therapy, psychological therapy, social work, nutrition, and everything else in between. And they have what's the equivalent of 3 months of outpatient care in 2 weeks. It's an intensive program. They recently opened this up to all veterans, so not just post 9/11 war veterans, but every veteran. So it's a wonderful program.
I want to ask you more about that, but first I stressed to with more of my planning here to ask you. So professional athletes, a professional athlete comes in and says in training, or not, he didn't say it, his coach says, or his trainer says, just that they banged his head on playing football, banged his head, like hit the ground with his head, saying, got knocked out, and was out for, say, 10 seconds. Would that player and a high school player who also hit his head on the ground, was out for 10 seconds, how do they react to your treatment? Do they attack your treatment the same way, I think? But generally not. I mean, not to shame kids or, struggling with the other issues, but like if they're do they attack with the same pickers, say a professional athlete who knows what their end goal is?
A little different.
Yeah.
And yeah, I mean, of course, a professional athlete, their livelihood is their job, right? So their need to play might be a little bit greater than a high school athlete. We think of our high school athletes, though, they really identify with themselves as athletes. That's their social group. That's their do every day after school. Those are their friends. That's their social network. That's what they've been working on too. So it can be equally as important for them to get back on their field or their court or on the ice. It may not be their livelihood, but as far as they're concerned, they don't know that this is their life at the time, because that's what they're going through. But of course you have, some high school kids who, maybe this is their way out. Maybe they're sick of playing. Their parents have been paying tens of thousands of dollars for 8 years of lessons and they don't want to quit, but maybe this is their way out. So certainly I've seen that as well, where they're like, you know what, I think I'm done. They still want to get better. They don't want to feel lousy. So as far as I'm concerned, we're still working on similar things.
And bringing you're doing the military aspect also in this, it's often, because obviously that would, I think, would also entail occupational therapy, psychology out there, tons of nutrition and tons of other therapists. I don't even know how to mention all of them. Definitely different types of therapists that would treat water veterans, but also must be the same as in, not the same, but similar to the same number of say therapists would also treat certain athletes and high school athletes as well. Do you often have it combined, they say, multidisciplinary therapy going with the athletes and military personnel and high school athletes?
Yeah, similar. So we like to be on the lookout for a high school athlete or a professional athlete or collegiate athlete who may need to see sports psychology or neuropsychology or social work or some other discipline. So we do approach this in a multidisciplinary fashion as well. And so I'm fortunate in Boston and at Mass General Hospital that I have access to some of the greatest therapists and physicians and colleagues out there across many disciplines and many different hospitals in Boston. So we
say Boston's there are tons of hospitals and I mean, especially brain injury related aspects of it. So Mass General, how big a hospital is that? Did your department say?
That's a great question. I don't know the answer to that. I know that about 20,000 people who work there.
Wow.
So it's you can imagine how many patients we see.
And there's also like the universities there and other hospitals as well, and even in the area. I mean, because I'm speaking from St. John's, where we're out in the middle of the North Atlantic, where there's no one near us. We're like us, and we're in Canada. Obviously, so we're not like desperate, but we're still like there's not much. Whereas in Boston is close to. I mean, they don't think are close to New York and Pittsburgh and all Philadelphia, these little ways. We are a lot closer than we are, and that's Hawaii kind of perspective, I guess. But
right,
yeah. So Kira, I want to ask you before you be ended there about the post-concussion syndrome. You do a lot with that, like the exercise and with post-concussion and with the other. And the atypical concussion presentations and considerations for the military. But yeah, mostly we'll go. So it's your first in the female athlete triad, which is mentioned in your bio. So I feel fine asking you about that. What is the female athlete triad?
Oh, sure. So I mean, that's outside of brain injury. That's more female athletes who maybe are under, don't have adequate nutrition and are at risk for any sort of bone stress injury or stress fractures. So that's just orthopedic side.
Oh, you want do you find that, is that affected though by, let's say, concussion? Would you say aspects to that are affected by if this person came to see you because they broke a leg, but they also broke a leg after a fall and like they didn't think they have it? Would you just say, okay, well, maybe something with you when you fell, did you head like, maybe hit my head, but my leg is broken, so that's the main reason I'm here. But would you also look at, say, their cervicogenic or their visuo-vestibular systems as really concussion? But that point is I'm kind of rambling here. But
Yeah, no, yes, certainly. If if they sustained multiple injuries to their leg and neck or head, I'm going to treat one, and assess each one fully. It might take a little bit longer, obviously, but yeah, I would still want to put as much effort into that. If I was suspicious that there may be some sort of head injury involved also.
And going back to the head injury, post-concussion syndrome, and if we see a preseason and postseason visuo-vestibular training to return to play decisions, what do you do for that?
Yeah, so this is mostly with the professional teams I see. So during their preseason physicals that they have with, the team physician, the orthopedist, the cardiologist, I'm one of the people they see as well. So every player on each of the Boston teams gets a full baseline test where I'll get baseline data on their oculomotor, vestibular, and balance, so that if they do sustain a concussion, aside from how they feel symptomatically, I have some preseason data to go on to see if they, are they performing where they did during their preseason test.
So do you feel that the baseline data is as important as some people think it is? Or some people think it's not important at all. But what's your opinion on baseline data? Do you need baseline testing? Is that needed?
To me, I think if you have the means to do it, I think it can be very useful. The two major areas that I find it the most useful is identifying those people who might have some baseline impairments that you could improve during the preseason. So if their tracking isn't where it should be, or if their balance or vestibular functioning isn't where it should be outside of having a concussion, so in the preseason, then maybe you can improve it with some prehab or some exercise, vision therapy or vestibular therapy. And then the other way is I found that some people just have abnormal baselines, like they might have an abnormal convergence or an abnormal dynamic visual acuity vestibular metric at their baseline. But if you don't have that and you're going to test it after their concussion and it's coming back as outside of the norm, and you keep working with them and not clearing them to go play because they're not testing within the norm, but you don't know that this is their norm, then you could be delaying return to play timeline. So it can help from that standpoint as well.
And I guess I don't say lastly, but second lastly or third last, whoever. Have you ever sustained a concussion that you require treatment for yourself?
So I am a lot older than concussion management has been around for. So I got a concussion in high school, which was in the 90s.
I've read your bio, you're not that old.
Well, I was in the high school in the 90s. And so nobody cared about concussions in the 90s. So I did get one, funny and not funny. I played soccer and basketball, but it was during track. I got my concussion during track, which is the ironic part, where I was fooling around after practice and was pretending I could high jump, and I was not a high jumper. And I went over the bar, fell off the mat, which was like a 10-foot high mat, and landed right on my head. But I didn't think anything of it. And I went along and just kept like horsing around. Yeah. And I didn't realize that I had a concussion until I had handed in an English assignment, and it was completely nonsensical. Everything I wrote did not make sense. And I was a good student. So my teacher flagged it and asked me to see her. And I did it a couple of days later, and I didn't recognize any of it. So then I was like, oh, but I didn't even call it a concussion. I didn't even know that word back then. And I didn't see any treatment for it because nobody knew that word.
No, exactly. I'm with the same type of but actually that kind of leads well into well, I was going to say it's my last question, but it's going for the longer one for you. But yes, but just the whole experience of just being an odd way to get a concussion, but your whole trajectory of your career started off getting a theater degree. Like, how does that?
Yep.
How do you go from theater to deciding that you want to be a physiotherapist?
That's a really good question. I ask myself that all the time. Yeah, so my undergrad was in theater and I was in New York City doing a lot of acting. And then after a few years of that, realized I wanted a career change, something that was a little bit more steady, that was I wanted to be doing something that I was helping people. And I come from a long line of teachers and nurses and doctors. And so I realized that's what I wanted to do. So I did the Teach for America program and I was teaching. So my master's degree is actually in education,
Yeah.
special education. So I was teaching kids with a lot of physical and cognitive disabilities. And there was a physical therapist and an occupational therapist in my classroom who would help get the children out of their wheelchairs so that they could participate in different ways in the classroom. And so while I was teaching over those few years, I realized that's what I want to do. I want to be working with bodies and brains. So then I had to do a post-bac pre-med program because I had to take 9 additional undergrad courses before I could apply to my doctoral program in physical therapy. But that's how a long way.
Yeah, took a long time because as you just was on to talk about her for the program, the Concussion Corner Academy, she mentioned that you were an actress yourself. So not yourself, Nick, because Jess is, but I mean you're an actress as well as a physical therapist. So do you still act, or do you give that up?
I mean, if you ask my friends and family, they'd say I'm acting all the time, but I haven't done anything in a couple years. I have kids in middle school. So my extra time, when I do have any extra time, is spent at soccer games and basketball games and coaching. But it's something that I think once they graduate from high school and I have some time back, that I miss it a lot. So I want to get back into some theater. I love it.
Yeah, I really miss it. So yeah, that means an interesting crossover for sure. But if you're physical therapy and you're obviously you're highly into that, and you're and acting, that's just an odd way to get there. But hey, however you get there, you get there, right? So
exactly, I wouldn't change any of it.
Exactly, yeah. So you said you started the instructing the course for I guess it's teaching, but sure it says instructing the course for Dr. Schwartz's Concussion Corner Academy in January. You said, you think?
I believe mine will be at the end of January.
Okay, and the name of your section of the course is physical therapy examination, and
my first lecture is examination of the oculomotor, vestibular, cervicogenic, and exercise. And my second lecture is the treatment, so the rehab part of it.
Wow. So that's like 1 week each, right? That's like
exactly.
So your one course is you'd be like not like an hour, it'd be like a week long just teaching about. So would that be with that I'm asking here. Would that be like very visual thing, or would that be just instructing? Because obviously now these people you're teaching would know exactly what you're talking about, really.
Yeah. So great thing is we have a lot of videos that we've pre-recorded of every single examination technique, with some great graphics to show like the exact parameters and everything. So I'll be instructing it verbally, but people will have access to the visual and all of the videos as well. So they'll really get some nice, some nice copies of what they can keep referring back to for specifics in instructional labs.
And you certainly got some great other instructors also in the course with you. So should be a very fascinating course. But
absolutely.
Before we end this now, would you just like to tell people how they can find you, and where is the best? Your link tree is where I found a lot of stuff, and that's also where I found a lot of links to the Mass General page, making a lot of info, and also Dr. Schwartz's program, which I know. But where how else do people find you, or if they find you or reach you or and on social media?
Yeah, so probably, and you can ask Dr. Schwartz. This is one of my biggest failures is my lack of social media prowess and knowledge.
That's no failure.
She's helping me circumnavigate the social media world to try to be more accessible. So Twitter is something that I'm on strictly for a professional reason. So that's probably, and it's just my name, Lenore Herget. So that is probably the easiest way for people to reach me. And then the whole Linktree Instagram thing is very new for me. So I'm learning that, but that's another way as well.
And if any Hollywood directors want to reach out to you, where they give any
all of the above.
Okay. Yes. Well, thank you so much for being part of this podcast.
Yeah. Thanks for having me, Nick. It was great talking with you.
Great talking with you. The music at the beginning of this podcast is by Ben Sound. www.bensound.com.